طيب السلام عليكم ورحمة الله وبركاته. Thank you for giving me this opportunity. Thank you to the organizing committee. In the next around 20-25 minutes, I'll talk about VTE prevention in oncology patients or in cancer patients. So some of the abbreviations that I will be using across the presentation will be VTE, of course, venous thromboembolism, and we mean by that DVT or deep vein thrombosis and pulmonary embolism, PE. CAT is basically cancer-associated thrombosis. DOACs are basically direct oral anticoagulants, rivaroxaban and apixaban mainly. Low molecular weight heparin, which will be as LMWH. So, cancer-associated thrombosis. The incidence really in reported cases ranges between 0.5% to 20%, and it really depends on the type of study that you look at, either is it retrospective or prospective. It also depends on what type of malignancy you're seeing, at what stage is that malignancy, and as well as is it a relapse or refractory disease. The highest incidence is among brain and pancreatic cancer patients, of course, and it does present as a significant morbidity and mortality cause for patients with malignancy. So it's well recognized that type of cancer matters. As we said, pancreatic cancer, if it becomes the highest risk for pancreatic cancer patients are at high risk for developing VTE, followed by lung, ovarian cancer, and least by breast cancer patients. Again, the stage of the disease, if you have metastatic disease, you're much at higher increased risk of developing VTE compared if you're at localized disease. Does it increase risk of death? So does developing VTE in cancer patient increases the risk of death? So yes, it does, and this was shown in this study where across all types of cancers observed, with the exception of kidney cancer, VTE increased significantly the risk of death within 1 year of cancer diagnosis. Whether this is related to the effects of thrombosis or reflects inherent tumor aggressiveness is unclear, but definitely most people do regard developing thrombosis in cancer patients as a sign of active disease rather than being a complication of the disease. The other issue with patients who do with malignant patients or cancer patients who unfortunately develop VTE, that they have higher recurrence of VTE, and when they are treated with an anticoagulant, they have higher risk of bleeding. So on your left-hand side, as you can see, cancer patients compared to non-cancer patients who have developed first episode of thrombosis, they have a higher recurrence rate. And on the right-hand side, clearly cancer patients, when anticoagulated, have higher chances of major bleeding compared to no-cancer patients. So all of these data have proven that VTE is a significant health issue and significant cause of morbidity and mortality in cancer patients. And that's what led people to think about prophylaxis in these patients. And the reason why cancer-associated thrombosis is more common, or patients with cancer have more risk of thrombosis, is basically can be divided into 4 things. So cancer-related factors, so primary site of cancer, advanced stage of cancer, what type of it, and what's the period after cancer diagnosis. Also the patient-related factors, so whether he is at an older age, has a history of VTE, has underlying thrombophilia, immobility or undergoing major surgery, higher ECOG performance, or race, ethnicity, and obesity. The other factors are basically treatment-related factors, and chemotherapy is one of the largest ones. For example, IMiDs in multiple myeloma patients are very well known to cause thrombosis. Hospitalization, chemotherapy, anti-angiogenic agents, central venous catheters, which are nowadays quite common in cancer patients. Biomarkers also having higher platelets, having higher leukocyte count, lower hemoglobin, tissue factor, soluble p-selectin, higher levels, or factor VIII have all been implicated in risk factors for cancer patients to develop thrombosis. So I'll be discussing primary prophylaxis for VTE in cancer patients. So we'll discuss basically these are cancer patients who have not developed any thrombosis yet. And we'll start with when these patients are hospitalized for whatever reason. So if they're hospitalized, they are most of the data are lacking in this situation, and there is an extrapolation of data from the medically ill patient in this to this population, and most of the guidelines would regard them as high risk patient and would suggest putting them on prophylaxis with low molecular weight heparin or unfractionated heparin as indicated. What about if they're going major surgery? So the inoxacan trial was a prospective double-blind multi-center trial in which patients undergoing planned curative open surgery for abdominal or pelvic cancer received enoxaparin 40 milligram subcutaneously once daily for 6 to 10 days, and after that they were randomized whether to receive placebo or enoxaparin for another 3 weeks or 21 days. And in fact, the people who got the extended, as you can see, they had a less recurrent or less thrombosis than the people who were on placebo, and that led the recommendations from the ACCP 2012 guidelines to extend prophylaxis for cancer patients undergoing major abdominal surgery up to 4 weeks post-discharge or from the time of admission. And in fact, in the more recent ASH guidelines in cancer patients, this recommendation still stands there. So this is the ASH 2021 guidelines. So for patients with cancer who had undergone a major abdominal pelvic surgical procedure, the ASH guideline panel suggests continuing pharmacological thromboprophylaxis post-discharge rather than discontinuing at the time of hospital discharge. So probably 3 to 4 weeks would be sufficient for these patients to lower the risk of thrombosis. So we're done with the with cancer patients who are admitted, with cancer patients who are undergoing surgery. So the big bulk of or the biggest population of our cancer patients are in the ambulatory care or in your outpatient setting. And these compromise are actually 80% of cancer-associated thrombosis occurs in the outpatient, not while patients are admitted. Probably the reason is that most of the hospitals are quite keen on prophylaxing them when they're admitted. Different cancers differ in their risk factors for VTE. As I have shown you earlier, breast cancer, even if metastasis, has a very low risk of VTE compared to, for example, pancreatic cancer. Trials comparing primary prophylaxis in low-risk cancers have shown non-significant benefit. And from the earlier trials that were done in the early 2000 and 2010, was the simulopatine for thromboprophylaxis in patients receiving chemotherapy for cancer, and another trial called nadroparin for the prevention of thromboembolic events in ambulatory patients with metastatic or locally advanced solid cancer receiving chemotherapy. So I'll just few words on these trials. So we'll start with the first trial, the simulopatine, which is basically a ultra low molecular weight heparin. It was the SAVE ONCO trial, and as you can see, yes, definitely they had lower recurrence risk of thrombosis, but at the expense of bleeding, they did have higher bleeding. And in the PROTECT trial that studied nadroparin, which is another type of low molecular weight heparin present in Europe, again, the same thing. They did have lower recurrences of thrombosis, but the thing was the absolute risk difference was low. So that wasn't really, and the same thing was seen in the SAVE ONCO trial, and that led not to be really applicable to patients. So the thinking was, and I'll show you in a few minutes, a subgroup analysis for the PROTECT trial. Probably the low-risk patients do not benefit the most from prophylaxis. And so both trials did confirm benefit of VTE reduction with no significant increase in risk of bleeding, but did not become standard of care because of absolute risk difference was small and there was no survival benefit. So after that, people started thinking, okay, so probably we need to classify patients to and provide prophylaxis for the higher risk patients more. And that led to the development of different risk assessment models. So the earliest one was Corona risk score, which basically incorporates site of cancer, platelet count, leukocyte count, hemoglobin level, or use of red cell growth factor and BMI in the score. Another improvement on that score was basically adding soluble P-selected D dimers. The PROTECT score added cisplatin or carboplatin-based chemotherapy or gemcitabine to the Corona score. Oncotev used the corona score plus certain other history-related VTE, metastatic disease parameters. CompassCat is a more comprehensive where it incorporates hormonal chemotherapy, anthracycline, time since cancer diagnosis, central venous catheter use, and other parameters. Tick Onco score as genetic risk score to Corona score, and a more recent one, which is the CATS normogram developed in the Netherlands, uses only two parameters, site of cancer and D-dimer, and they have a risk assessment tool which is available online for use. But the only thing is, the out of all of these scores, these are all of them almost all of them are prospectively validated, but none of them have been used in a prospective trial where you decide about clinical judgment, except for the Corona score. So that's why we'll go a bit more detail in the Corona score. So as I said, the parameters, and that's the score for you. And initially, they dichotomy or they divided the population into three: a low risk group, which has basically zero score; an intermediate risk group, which was 1 to 2; and a high risk group, which was 3 or more risk factors. And it did really show that the high risk group did have the highest risk of developing thrombosis, as you can see. And looking back to the PROTECT trial with the subgroup analysis retrospectively, of course, if you looked at the population who got the prophylaxis, in fact, the people who were by Corona score high risk were the ones who benefited the most from the prophylactic strategy. And that led to the to two randomized controlled trial. So the first one used apixaban, which is a direct oral angiotensin A agent, to prevent venous thromboembolism in patients with cancer, the AVERT trial. So it was a placebo randomized controlled trial that basically took newly diagnosed patients with or patients with cancer, and in the ambulatory setting, and basically divided them into either placebo or prophylactic dose, which is 2.5 milligram of apixaban twice daily. But they should have had a Corona score of 2 or more. So really, not your. They did include some of the intermediate risk as well as the high risk group. And their primary efficacy outcome was objectively documented venous thromboembolism over a follow-up period of 180 days. And the main safety outcome was, of course, major bleeding. So that's just shows you. So it's a 6-month trial followed by 1 month of visit or phone call just for follow-up. And give you an idea, if we apply this in our clinical setting, so they actually screened around 1,800 patients, and they got eligible patients, which were around 574. So almost around 1/3 of patients, so 30% of your patient would be eligible if you apply this risk assessment model. And the type of tumors that they mainly had were basically lung, pancreatic, lymphoma, and gynecologic tumors. And I would just highlight you that gynecologic tumors were around 25, 1/4 of the patients. So looking at the data, definitely apixaban patients, so the patient on the trial medication did have a lower incidence of thrombosis, but at the expense of major bleeding. So major bleeding was higher among patients on apixaban compared to placebo. So apixaban therapy did result in a significantly lower rate of venous thromboembolism than did placebo among intermediate to high-risk ambulatory patients with cancer who were starting chemotherapy. The rate of major bleeding episode was higher with apixaban than with placebo. And probably the reason behind that, most of these bleedings, as reported in the trial, was driven by GI and GU malignancies. And as I showed you, that around 1/4 of the patients did have gynecological malignancy. So that's, and in the other trials of DOACs, which preceded the trial, were basically in the treatment setting of cancer-associated thrombosis, patients who had GI and GU malignancy were at higher risk of bleeding. So this data was consistent of the previous trials of DOACs. Another, just one small thing here, if you calculate the number needed to treat in the AVERT trial, it's 1 in 16, so 16 basically. So you need to treat 16 patients to prevent one thrombosis from occurring. Then the Cassini trial also was conducted, which basically used rivaroxaban, another oral angiotensin agent, for thromboprophylaxis in high-risk ambulatory patients with cancer. It's really similar design, same use of the corona risk score. The only thing was they did one interesting thing, which was they screened patients for thrombosis prior to entering the trial. Uh, and in fact, so this is a trial design. They got around 700 patients, randomized them from day one to either rivaroxaban 10 milligram once daily versus placebo. Same thing, followed for 180 days and 1 month extra follow-up there. So they screened around 1,000 patients, and after exclusion and that, they got around 80% of the patients were eligible, and around 5% of the patients, which is around 49 here, had evidence of DVT on screening. So these are basically just screening, and they were excluded because of that. So around 5% of the patient did have incidental DVT, if you can say. Anyhow, so again, the major tumor sites that were in the trial consisted of pancreatic, gastroesophageal junction, and lung cancer. They did also have some lymphoma patients, some ovarian patients, but to a much lesser percentage. Their primary composite efficacy endpoint was basically, and I would highlight this is a primary composite, symptomatic or asymptomatic lower extremity DVT or upper extremity DVT, pulmonary embolism, or VTE related death. So that's the composite outcome. Secondary confirmed outcomes, arterial, visceral, or all-cause mortality. Safety, of course, major bleeding, and clinically relevant non-major bleeding were the safety endpoints. So as you can see, primary events at day 80, all randomized patients, so on an intention to treat analysis, didn't make much difference in this, and probably the reason was the compliance of patients. But when you looked at the patients that were on treatment, that they didn't have any treatment interruptions, there was actually a significant difference between the patients who received rivaroxaban compared to placebo, and the rivaroxaban patient did have a lower event rate. And if you look at the composite endpoint that I highlighted earlier and all-cause mortality, actually patients on rivaroxaban prophylaxis had a lower chance of the composite endpoint and mortality and all-cause mortality. But this is adding all of the outcomes together. So the primary efficacy composite endpoint with all-cause mortality showed some survival benefit in this study. Major bleeding was not significantly increased between rivaroxaban or the placebo arm, as well as the clinically relevant non-major bleeding. Again, site of major bleeding including GI, intraocular, intracranial, and fatal bleeding in only one patient on rivaroxaban. So the number needed to treat here, if you just took the primary efficacy endpoint was 35. If you add to it the secondary efficacy endpoint of all-cause mortality, then it comes down to 17, where the number needed to harm is quite high, in fact. So again, it did show significant decrease in thrombosis with no significant harm in the ambulatory care of cancer patients. So rivaroxaban significantly reduced VTE and non-significant VTE-related death during the on-treatment period, but not during the full study period. The corona risk score cutoff of 2 or more identified cancer patients at high risk of thrombotic events, both at baseline and during the study. So as you have seen, all those trials basically studied a group of malignancies, and in fact, it has been published previously that the corona scoring system doesn't work that well in multiple myeloma patients. So the International Myeloma Working Group and the European Myeloma Network and the NCCN guidelines have proposed this from 2014 as a risk scoring system for myeloma patients in order to decide which type of prophylaxis should they receive. It's a quite comprehensive, which includes patient-related factors, disease-related risk factors, as well as treatment-related risk factors. And basically, if you have 0 points, you're low risk. If you have 1 point, you can go with aspirin at 100 milligrams daily. If you have more than 1 point, you can either get low molecular heparin as prophylactic dose or therapeutic dose of warfarin. And more recently, 2019, two different groups developed two different scoring systems for myeloma patients. So the IMPEDE VTE score, which uses certain scoring systems, so IMIDs, thalidomide, lenalidomide, or pomalidomide, uh, BMI, pathological fractures, erythropoiesis stimulating agent use, dexamethasone, high dose or low dose, doxorubicin, ethnicity and race, VTE history, tunnel line or central venous catheter, existing use of therapeutic warfarin or low molecular weight heparin, existing use of prophylactic low molecular weight heparin. It's a scoring system that you can use, and then you can decide if your patient is low risk, intermediate risk, high risk. On another group, again, similar database, they developed different scoring system, which is called the SAVED score. Basically uses surgery, Asian race, VTE history, um, age, and dexamethasone dose, whether standard or high. But the SAFE score was really developed for patients who are receiving IMID-based regimens only, and they were able to divide their patients into either low risk or high risk. Reminding you, these two scoring systems need to be prospectively validated. They have only been retrospectively and externally validated. They also need to be used in a, or sorry, these groups didn't have any recommendations after dividing your or classifying your patients on what type of prophylaxis to use. Where the International Myeloma Working Group did say either aspirin or low molecular weight heparin or warfarin, depending on the risk score that you get. So this is a nice effort looking at single malignancy, multiple myeloma, and trying to develop scoring systems. And that leads me to my last question, which is why hasn't the risk assessment been adopted by hematologists or oncologists universally? And probably the reason are the lack of uh, robust data. So we do have randomized trials, but then the randomized trials include all patients of different malignancies, so breast, GI, lymphoma. And when you start looking at the bulk of the patient, you see probably your patient doesn't fit in that risk scoring system. That's one thing. Secondly, the effect may differ between intermediate as well as the high risk group. As you have seen, the coronary score does include intermediate patients in their decision, so that may affect your outcome. So a lot of people do believe that probably my patient isn't that high risk to deserve prophylaxis. Definitely, but definitely one thing everybody does agree, and in fact, most of the international guidelines regarding cancer-associated thrombosis do agree on, if your patient is a high-risk patient, then he has to be on some type of prophylaxis in the ambulatory setting. So I would conclude with saying that all cancer patients should undergo risk assessment for VTE. Intermediate to high risk patients may be considered for DOAC's prophylaxis, since the trials were done on DOAC. Drug to drug interactions, patient's preference between either injections or DOACs, and bleeding risk should be considered prior to prescribing any prophylaxis. That I end my talk, and thank you for listening.